Hello, everyone. Welcome to this webinar organized by Frontline AIDS on improving HIV programming for and with LGBT people. Before I continue, I would like to attract your attention to the fact that we are providing interpretation for this webinar. Interpretation is provided in English, provided in Portuguese, and also in French. What I would like to ask you to do is to please select the language you want to listen to using the interpretation function at the bottom of your Zoom window. I think we have a slide that should show you how to do that. Maybe we can go there. Yeah, exactly. As you can see here, please make sure to choose the little globe icon at the bottom of your screen and pick the language you want to listen to the webinar in. So there is English, French, and Portuguese. I recommend also English speakers to please select English, because we will be having a speaker which will speak in Portuguese. So please make sure you do that now. I'll just wait a couple of minutes, and in the meantime repeat that. So welcome to this webinar organized by Frontline AIDS about improving the care cascade and the care continuum for LGBT people. We are providing interpretation. We are providing interpretation in French and Portuguese and English. To do that, please make sure you look at the bottom of the Zoom screen on the black bar. Look for the little globe icon as this image is showing, as the slide is showing, and select the language you want to listen to. We are providing English translation, French and Portuguese as well. And if you do that, please make sure to stay there. We will have one of the speakers speaking in Portuguese, so even English speakers are recommended to select English from the interpretation channel. Welcome, everyone. We're just giving it a couple of minutes to make sure that everybody has the time to choose their language. As I said, we're offering interpretation in 3 languages, in English, in French, and in Portuguese. Please make sure you follow the instructions in this slide and select your language from the bottom, from the little translation icon at the bottom of the screen. All right, I think we're good to start now. Again, let me welcome everyone today at this webinar organized by Frontline AIDS. The webinar topic is improving the HIV continuum of care for and with LGBT people. I wanted to thank you, especially because I know how busy you must be at the time of the year. But it's really good that you made some time to be with us. The webinar will last a total of 90 minutes. We've invited you for 2 hours, but we're hoping to only steal 1 hour and a half of your time. Before continuing, I just wanted to tell you that this, as you know, this webinar is hosted on Zoom webinar function. For this reason, your microphones have been disabled. However, if you wish to ask a question, please use the Q&A function at the bottom of the screen. We're really looking forward to your questions and to having a very nice discussion. There will be opportunities for 2 discussions throughout our time together. We're really aiming at answering all your questions. So please don't be afraid, use the Q&A function to make any comments or questions. And the last thing I wanted to say is that the webinar is going to be recorded, so we will make it available once it's ended. Okay. I wanted to maybe spend a few words and tell you why we have decided to have this webinar. So maybe if I could have the next slide. So thank you. So why this webinar? So out of 193 countries in the world, we still have 68 countries that have laws that criminalize same-sex sexual activity. In 11 of these countries, death penalty is the punishment that is there for men and women who engage in same-sex sexual activity. And in 8 more of these countries, there is life imprisonment for people who engage in this type of activities. But not only, it's not just about criminalization. I think I can say it without any worry that you know, LGBT people all over the world have experienced discrimination in one form or another. And it's not just about, you know, not criminalizing or not discriminating. It's also about ensuring that there are laws that protect the rights of LGBT people. And throughout the world, the countries that do that are very, very few still. What is the problem though? The problem is that when people are criminalized, LGBT people, like many other marginalized groups, like other groups that we call key populations, find it hard to access health services, to access HIV services in health facilities. So for this reason, we need to come up with strategies, with ways of bringing services closer to them. At times, this means coming up with services that can reach deep down in the communities where LGBT people are. At times, it also means working with health facilities to ensure that the health facilities themselves become a friendlier place, a place where LGBT people can access quality services without the fear of being discriminated. So today what we're doing with this webinar is telling you the stories of 3 projects that in different ways try to do precisely that. They were active at the community level, they were also active at the health facility level to make health services more acceptable to them. One last thing before I pass on the mic to my colleague Savita, who will help us moderate this webinar, is that when you plan services and projects for LGBT people, you really have to look after their safety and their security first. So strategies to avoid any harm to the people who are implementing the project, but especially also to the people that are receiving the services from the project, especially if they're LGBT people, are very much needed. So I can't stress enough the importance of thinking about, you know, ways to prevent and to address any forms of insecurity, any forms of threat that might be brought to LGBT people because of your project. So this webinar is not focusing on that, but I just wanted to stress that this is really an important part, and all these 3 projects really had very solid systems to address this type of incidents. Just, you know, in April this year, during the COVID lockdown in Uganda, 20 LGBT people were arrested in a safe space simply because they were accessing services together. And the police there arrested them, charging them with because they were risking to infect other people with COVID. That were all excuses. They had to stay in prison for over a month before they could be released. Some of them were even tortured during that time. So just as an example, I mean, thank God now these people are out of jail and they're doing fine. But just to say that, it's really, really important that we reflect on what the projects need to do in order to protect the safety of LGBT people. All right, and now without further waiting, I just would like to introduce Savita. Savita works with me at Frontline AIDS, and she's a project lead. Savita, please, next.
Great. Thanks, Matteo, and welcome everyone to the webinar. It's really great to see you all here. Kristen, if we can move to the next slide, please. So as Matteo said, this webinar is going to be focusing on the learning from 3 key projects. And these projects were implemented in Kenya, Uganda, and Mozambique. And all of these projects were funded by the Elton John Foundation under a mechanism called the Deep Engagement Grant. And they focused on HIV programming for LGBT communities in each of these 3 countries. Each of the projects were roughly the same duration, around two years. The longest project was Mozambique, 2.5 years, and Kenya was about 2 years. And just to also relay, the results of these projects are relatively recent. So 2 of the programs ended this year in 2020, and the Kenya project ended at the end of 2019. So the learnings and the strategies and the reflections that we're going to be having today on the HIV continuum of care and LGBT programming is very much sort of from these very recently implemented programs. As we can see, the programs were implemented in a variety of districts and regions, so had relatively good outreach. And in Kenya, amongst other areas, the project was implemented in Nairobi, Mombasa, and Kagwale. In Uganda, project sites included Kampala, Mbale, and Entebbe. And in Mozambique, we had Maputo City Province, Nampula, and Cabo Delgado. We can also read on this slide that there were a variety of partners that came together to enable these projects to be implemented. And I always find it so encouraging to see the diversity and number of partners all coming together to really focus on improving the continuum of care for the LGBT community with HIV prevention, testing and treatment, and the networks that these projects enable in terms of going forward with the same mission. If we go to the next slide. All the organizations are also represented here. And we would like to really take the opportunity to thank all the partners for their work in this collaboration and in this joint programming around each of the deep engagement projects. And also especially to the frontline workers, including the peer educators and the health practitioners such as nurses, for working and implementing these programs. And as Matteo highlighted, an often very challenging context that are sort of when we're thinking about safety and security and we're thinking about criminalization, they're not easy contexts to work in when we think about LGBT programming and advancing the rights of people and their right to health and working on HIV programming. We would also like to thank the Elton John Foundation very much for the investment made in the deep engagement programming across the 3 countries and the collaboration. We're now going to have the opportunity to go into the main body of the webinar, and it gives me really great pleasure to introduce our 3 main speakers, the panelists. We have Dr. Pasquin Ugansanya from Alive Medical Services, who's the ED in Uganda. We've got Patricia Jakania, who works for LVCT Health in Kenya as the Senior Technical Advisor in Policy and Partnerships. And we also have Roberta Paulo, who is the Executive Director in Lambda in Mozambique. And just to note, even though we've given a highlight of these 3 projects in each of the countries, we're actually going to be focusing on 3 of the key strategies that were commonalities in the 3 programs, all focusing on the HIV continuum of care. And each of the presenters will be taking forward one of the key strategies and sharing the learning insights and reflections for those key strategies from each of the 3 countries combined. So Patricia will be talking about peer outreach strategies. Roberta will be guiding us through the safe spaces strategies. And finally, Dr. Pasquin will be talking about the healthcare workers and talking through that strategy around health clinics and outreach. So without further ado, over to Patricia to guide us through the peer outreach strategies.
Hi, everyone, and thank you, Savita. So I will go ahead and present on the peer-based outreach strategy design and the lessons that were learned across the 3 countries, that's Mozambique, Kenya, and Uganda. And across the 3 countries, we had about 60 peer educators who were recruited to work with the LGBT groups, both in Kenya and in Mozambique, specifically targeting different age groups. So as we know, we have the much younger LGBT and the older ones. So there was a mix even in the age of the peer educators. And all the peer educators were also asked to take an initial training. So for Kenya, we have the key populations curriculum that is under the National AIDS and STIs Control Program. And then there was self-development for Uganda and Mozambique. All the peer educators received employment contracts, and the stipends that they were given ranged from between 27 in Uganda, 48 in Kenya, 140 USD in Mozambique. However, in Uganda and Kenya, peer educators received per diems with each mobile clinic conducted. For Kenya, we call it mostly the Moonlight. And then services provided by peer educators included condoms, lubricants, and for condoms, it went also with the messaging around consistent and correct use of condoms, communication on HIV prevention, so there was risk reduction counseling, and also linkages and referrals to safe spaces and facilities. So there was that connection between the community spaces and the health facilities. Peer educators in Kenya and Uganda could also refer MSM and LGBT populations to take PrEP. Next. So there are unique things that stood out in each of these countries that will be the focus of this slide. So in Kenya, for example, we had peer educators were also working twice a week in public health facilities, and this being a pilot in a space where initially there were no services in public health facilities. So this was an opportunity, and there was that working relationship between the peer educators and the providers within the facilities. And this also happened in Mozambique, but it happened towards the end of the project to improve linkage to services. In Kenya, peer educators' remuneration was also tied to their performance. So in Kenya, there was LVCT Health, there was PEMA Kenya and Nyarwek, who engaged peer educators, and peer educators had targets that were reviewed every month. So if a peer educator, for example, did not meet their target for 2 months, there would be discussions about their continuation within the project, or even in terms of their remuneration. In Uganda, peer educators were able to refer beneficiaries for free legal counseling in cases of human rights abuses or violence. In Uganda, one LGBT-led organization, that is Spectrum, had a toll-free line where the LGBT community were able to actually call and get services, get referred for several services across the country. And this is because in Uganda, there's a lot of stigma and discrimination and violence that targets the LGBT community. In Mozambique, through a collaboration with the Ministry of Health, peer educators were trained in HIV testing and counseling. And this really proved to be effective in Mozambique, where the peer educators who had been trained could link the HIV positive LGBTs to the nearest facilities to take up other services. In Mozambique also, two virtual peer educators were employed. And so these ones would basically work on maintaining their social media presence. Next. Next. So in terms of the results that were documented during the implementation of these projects in Kenya, we were able to get 13,876 LGBT persons who are reached with various services. And again, this ranged from lesbians, gay, and under bisexual. We disaggregated the data further into bisexual men, bisexual women, and transgender. And in Uganda, they got 16,505, and again disaggregating them by the age, by the subpopulations: lesbians, women who have sex with women, gay, men who have sex with men, transgender, and there were others. So others would be other people who came into the project but could not identify as LGBT. And then in Mozambique, 20,937 were reached with services, again disaggregated by the subpopulations of lesbian women who have sex with women, gay and men who have sex with men, and transgender. Next. In terms of lessons, so in the different countries, we engaged older LGBT or MSM persons 35 years and above, who would basically be targeting older MSMs who are sometimes difficult to find. They were professionals in their different areas. And so in Kenya, in Mozambique, there was the same approach. In Uganda, TASO adopted the peer-driven referral strategy to penetrate networks of the older LGBT people. And as we know, for example, in Kenya, the older LGBT would not be found in the usual hotspots. So again, getting the older peer educators to find the older LGBT MSM people made it much easier also for the referrals. In Kenya, the mobilization of LGBT to attend health facility, the public health facility, also was very specific to certain days and certain times where the peer educators would work with the facilities, and you create that enabling environment for the LGBT people to be able to access services. In Mozambique, HIV testing at the community level was found to be very appropriate. Remember in the previous slide, we said LGBT people were also trained to be able to provide testing. So they took this to community settings like safe spaces, hotspot level, and even to the homes of the peers. In Uganda and Mozambique, it became clear that LGBT hotspots could rapidly change. And this was equally similar also to Kenya. And so there was a need to constantly, update the different locations as they came up. Next. Next. So in all the three countries, peer educators were the foundation of these projects. As we know, LGBT are hard to find populations. So it was actually groundbreaking to have peer educators working within the projects to provide, the technical skills, be able to do counseling for their peers, and also to be able to monitor a lot of the work that was happening. So to be able to achieve all this, there was very close monitoring of peer educators in terms of the performance assessments, sitting with them on a weekly basis to just find out what was happening, and also very much guided on the do no harm policy to ensure that there was no harm on the peer educators as they were conducting their work. In Mozambique, Lambda decided to significantly increase the salaries of the peer educators who are employed within their projects, and this decision had a very positive effect on the peer educators and ensured that they were able to achieve their targets. In Kenya, the fact that LVCT Health and the partners tied the peer educators' remuneration to performance, pushed them to expand their networks, venture into new spaces, and also be able to focus on especially the LGBT who are hard to reach because they are the ones who are not covered by the usual programs that we have targeting LGBT. Next. So at this point, I would like to welcome Roberto Paulo, who is the Executive Director of Lambda from Mozambique. Welcome, Roberto.
Bom, muito obrigado pela palavra. Bom, para a Lambda foi grande privilégio fazer parte. e rapidamente vamos partilhar aquilo que foram os espaços seguros implementados dentro deste projeto. Primeiro dizer que o espaço seguro é um local estabelecido para que a comunidade LGBT ela possa, de alguma forma, interagir sem o receio de discriminado ou estigmatizado. No caso concreto, neste projeto específico, nos 3 países, foram estabelecidos um total de 20 espaços seguros, sendo 14 em Quênia, 6, aliás, desculpe, 3 em Moçambique e 3 em Uganda. 3 em Uganda, e os espaços seguros, digamos que eles, de alguma forma, como foram 20 espaços seguros, portanto, 14 no Quênia, 14 Quênia, 3 Moçambique, 3 Uganda. E em termos de serviços, os espaços seguros, eles tinham um serviço de socialização, onde era possível, por exemplo, jogos, sons de karaoke, ter festas da comunidade LGBT, ter livros para leitura, ter lavandaria para que as pessoas pudessem lavar a sua roupa. Por outro lado, também havia uma série de serviços com vista a empoderar a própria comunidade LGBT, como cursos diversos sobre várias áreas, como dança, como habilidades para tanto dança, literacia, cursos de informática. E, por outro lado, importa salientar que no Quênia, por exemplo, nós tivemos um abrigo que era para oferecer para apoiar as vítimas de diferentes tipos de violência. Por outro lado, também nos espaços seguros eram oferecidos serviços clínicos. Nós tínhamos em cada um dos espaços seguros gente treinada para oferecer os serviços clínicos, eram educadores de previamente formados, mas também tínhamos brigadas móveis que deslocavam-se para os espaços seguros, gente treinada para oferecer serviços clínicos, gente esta que vinha de unidades sanitárias com as quais tínhamos acordos de colaboração. De um modo geral, o slide a seguir, por favor. Bom, de um modo geral, os espaços seguros eles foram uma inovação para aquilo que é a oferta de serviços amigáveis para a população LGBT, sobretudo em Moçambique, porque nós nunca tínhamos tido espaços como estes direcionados para a comunidade LGBT. No Quênia, por exemplo, podemos mencionar que o mecanismo de resolução de conflitos que tinha sido estabelecido ajudou bastante a melhorar o ambiente de trabalho, tanto dos educadores de lar como com os seus beneficiários. É importante salientar que na Uganda nós tínhamos uma linha de apoio que funcionava 24 horas por dia, oferecendo serviços aos diferentes beneficiários, onde era possível ligar de forma anônima e receber serviços de atendimento com a maior discrição possível. Aprendemos igualmente a importância de capacitar os educadores escolares em lidar com casos de violação de direitos humanos, ou seja, como assegurar que os educadores de base, ao nível da comunidade, possam, portanto, reportar casos de violação de direitos humanos, fazer o devido seguimento para que os beneficiários possam, eventualmente, receber o devido apoio jurídico que é necessário. Slide a seguir, por favor. De um modo geral, podemos afirmar que a nossa experiência mostrou que nos 3 países os centros, espaços seguros tiveram uma maior frequência de população jovem. O slide a seguir, por favor. Sim. Então, como dizia, nos 3 países a maior frequência foi de gente bastante jovem, e é fácil compreender isto porque os jovens são uma população que, digamos, estão muito imiscuídos, não têm muito receio com a população adulta. Quando falamos ligados à socialização, os jovens interagem com maior facilidade em relação à população adulta. E aquilo que nós vimos é que geralmente as pessoas mais adultas organizam festas mais privadas. Em Moçambique, nós tivemos um grande desafio de identificação das casas, porque infelizmente alguns proprietários dos imóveis, ao saber que este espaço para um programa para a população LGBT, a tendência sempre foi circular. Foi um grande desafio encontrar locais para implementar estes espaços seguros. Igualmente foi um grande desafio porque era preciso trabalhar com os vizinhos de diferentes espaços seguros para que eles fossem mais amigáveis, no sentido de não discriminar as pessoas que procuravam receber, portanto, os espaços que eram oferecidos nesses espaços seguros. No Quênia, foi possível constatar que, mesmo com a integração dos serviços de saúde, os espaços seguros jogaram um papel fundamental, porque a procura de serviços nos espaços seguros foi, digamos, maior, porque as pessoas sentiam mais segurança e tranquilidade em ir lá buscar os serviços de saúde. Por outro lado, em Moçambique, nós tivemos uma situação em que nos espaços seguros era possível trazer familiares de população LGBT para que pudessem aceder serviços e fossem aconselhados para não discriminar as populações LGBT. De um modo geral, podemos afirmar que os espaços seguros são uma estratégia extremamente funcional e que permite que possa criar demanda para a provisão de serviços clínicos que precisamos oferecer à população LGBT. Bom, muito obrigado, vou parar por aqui e tenho a honra de convidar a minha colega do painel, a doutora Pasquim, da Life Medical Service, portanto, vai seguir com a apresentação. Muito obrigado.
Hello, everyone. Thank you for attending this webinar. I will be sharing with you about the strategy of the health workers. Next slide, please. So the strategy designed for the health workers, we had 3 components. So the startup component was when the LGBT and MSM identify health facilities that can provide them with services. And this was both in Kenya, Uganda, and Mozambique. So in all the 3 countries as well, there was a buy-in and agreements with country health departments and district health departments. And then we also had to train the health facilities and the health workers in these health facilities in providing LGBT and MSM friendly and quality services. Under implementation, in Kenya, we had secondment of project staff in health facilities. And in all the 3 countries, we provided medicines that included ARVs, medicines for opportunistic infections, STI medicines, as well as treatment for hepatitis B and C, And we also provided other supplies in all the 3 countries. In all the 3 countries also, we had both static clinics and mobile clinics that included moonlight outreaches and with full involvement of the peer educators. And in all this, in the outreaches and also the clinic, we integrated services so that is a one-stop medical services. We also were able to monitor the services we were providing. In Kenya, they had monthly continuous medical education, which was a continuous quality improvement, so that anything that arose, they would address. And in all the 3 countries, they had quarterly meetings with the district and with the country level and the health workers, as well as the peer educators. Next slide, please. So what was the learning that we had as we were implementing this project? We saw that in all the 3 countries, health providers' attitudes towards LGBT and MSM can bar access to services. It was very important that at the beginning of the training, we focused on attitude and value clarification. In Uganda and Mozambique, at the beginning of the training for the health workers, we had the LGBT community come to the training to create acceptance and also increase understanding on how to take care of their needs. In all the 3 countries also, facility mentorship, we learned that if we only focus on the health providers and leave out the other staff, there will still be stigma and discrimination. So we also went ahead and mentored hospital security, receptionists, and front desk staff to be able to provide stigma-free services. In Kenya, they had a challenge with a high turnover in the public health facilities that would affect continuity of quality services. And in Uganda, we also learned that doing mobile clinics and integrating HIV services with provision of hepatitis B vaccination and treatment significantly increased the number of LGBT and MSM coming to attend the clinic and also coming to attend the services at the mobile outreaches. In Kenya also, we learned that investing in the buy-in from the county health at the beginning of the project was very important because it enabled fruitful collaborations, but also continuity and sustainability. In Mozambique, beneficiaries who tested positive in the mobile clinic found it difficult. They had less chance of being linked immediately to care compared to other HIV positive beneficiaries. Next slide, please. So right now we're going into discussions and I'm going to hand over, we're going into questions and answers. I will hand over to the moderator from Frontline AIDS. Over to you, Matteo.
Thank you, Dr. Pasquin. And thank you so much, everyone, for being with us so far. I see we already have a couple of questions here on the Q&A function. We're going to have now about 20 minutes to have a discussion around these 3 approaches we've heard so far. So the first one was, of course, the peer-led approaches that all partners have adopted in these 3 countries, in Kenya, Uganda, and Mozambique. So if you have questions about that or anything wasn't clear, that's the time to ask those questions. We also heard from Roberto about safe spaces and how they also provided an environment for LGBT people to access services and socialize. And then we heard lastly from Pasquin on the strategies the projects enacted to collaborate and work with health facilities. So let me just go to the first question that I see here. The question is from Lazarus. from TASO Uganda. TASO was one of the organizations that was implementing the project in Uganda. TASO was managing a number of health facilities that was providing services to LGBT people all throughout Uganda. So the question that Dr. Lazarus has, I think it's for Lambda in this case, so it's for Roberto, and it's about the virtual outreach strategy that the project had enacted. So Roberto, could you please maybe give us or spend a few words describing what the project did, particularly in relation to the role of the virtual peer educators, and also the website and the WhatsApp groups and the Facebook page. Thank you. Roberto?
Bom, muito obrigado. Bom, muito obrigado pelo nosso... Bom, peço imensas desculpas, houve barulho com o vento, imensas desculpas. Bom, muito obrigado. De facto, nós implementamos a estratégia virtual, na qual consistiu com a contratação de 2 educadores de par, que foram devidamente capacitados naquilo que são as diferentes estratégias para mobilizar os beneficiários de uma forma virtual. E em seguida fizemos um mapeamento das diferentes plataformas virtuais às quais os nossos beneficiários referimos à comunidade LGBT, é mais frequente, e a partir dali o navegador virtual tinha a missão de entrar nestas diferentes plataformas e fazer a sensibilização dos beneficiários por estas plataformas, e em seguida os beneficiários então eram referidos para os serviços presenciais, caso estes, por exemplo, precisassem de receber preservativos, lubrificantes ou testagem para o HIV. Por outro lado, nós criamos uma página denominada calor.online, que era uma página específica, e a página estava dividida em diferentes segmentos. Havia um segmento para assuntos ligados a mulheres bissexuais e lésbicas. Havia uma outra parte da página que estava ligada apenas a homens gays e homens bissexuais, onde para cada um dos compartimentos desta página do website estava colocada informação específica em termos de saúde para o respectivo grupo. E também tínhamos uma espécie de um diretório na página onde, dependendo de onde o beneficiário estiver, era possível entrar na página e saber a partir da cidade onde o beneficiário está, quais os locais onde pode buscar apoio, tanto em termos de acesso a insumos de prevenção, como, caso quisesse, serviços de testagem para o HIV. De um modo geral, era assim como funcionava a nossa estratégia virtual. Obrigado.
Thank you so much, Roberto, for this. Maybe let's take the second question. There is a question here again from TASO Uganda, specifically now asking about the toll-free line, and that, you know, that in this case, one of the partners in Uganda, Spectrum Uganda, adopted as one of their ways of doing peer outreach. The question specifically asks, how safe was the referral done by a telephone for LGBT people? Dr. Pasquin, would you like to take this question? If you have the answer, I can also, in case, intervene here and spend a few words. But first, let me have you address the question, Dr. Pasquin. Thank you.
Yes, I think this was safe. We have not had any incident that there was maybe a challenge or breach of confidentiality. It was safe, and the way it was organized, it was very beneficial, but safe. But of course, I have Spectrum also on this. I can see Isaac is around. If there's need, he could throw more light, but if not, Matteo, you can throw more light.
Oh, for sure. No, if there is a way we can, Kristen, if there is a way we could unmute Isaac, who is, of course, at Spectrum Uganda, that would be great.
Yeah, 1 second, I'll find him.
Thank you. In the meantime, as you find him, I just want to say that we did actually quite a study on the toll-free line. So to verify some of these information, and as we wait or see if Kristen can identify Isaac, I just wanted to share, for instance, specific in relation to your question, Lazarus, what some of the work that Spectrum Uganda had done, even this project, to be honest, was to map health facilities across the country through their peer educators and identify the ones that were providing care that is friendly towards LGBT people. They had put that in a list that was available to the peer educators answering calls on the toll-free, made it available via leaflets to all LGBT people that came visiting the office. So, so just to say that, of course, there was this mechanism. Let me start my video so you can see me. There was this mechanism to make sure that people accessed and were referred to clinics that the organization knew was providing friendly care. They were also, of course, trying to make sure that through their contacts with the health facilities that the person had actually gone after being referred. The challenge with that, of course, was that most of the people who took advantage of the toll-free line did so in anonymity, so without providing either a real name or providing a name at all. So this becomes complicated, of course, to then verify at the receiving end if the referral has been completed or not. But in those cases where patients or LGBT people provided a real name, then of course there was a system to verify if the referral was complete. I don't know if Isaac is now with us. Maybe Isaac, if you want to add a few bits here, that would be really helpful. Thank you.
Thank you so much. Can everyone hear me? I don't know.
Yes, we can hear you very well. Thank you, Isaac.
Okay, Matteo really put it out so clearly. One of the things that we did as a measure was to map out all the service centers, develop a referral directory that had all the contacts. And this is what we use. So whenever we got a call, for example, the person is based in Busia, we knew the centers in Busia, we knew the contact person in Busia, and we had a peer educator in that area. So we definitely do a linkage through the peer to the facility. And honestly, in that way, we did not have challenges. But of course, we had also targeted callers, people who would call just to abuse us. We had government people who would call us. But as a strategy also in line with that, the person who was handling the line was well trained to know how to handle fake calls, how to handle calls that are targeted to bring insecurities. And in the end, we did not have any major challenges of having people targeted. Maybe, for example, someone trying to access services and then ends up getting arrested. I think we really worked around it. Yeah, thank you.
Thank you. Thank you so much, Isaac, for giving a few more details about that. Really great to hear also your voice. I have another question here, which is a quick one, and I think I can address it. It's a question that asks if safe spaces are different or are the same thing from the organizations, the offices of the organizations that were managing the project.
Mateo?
Yeah.
Would you kindly just summarize what Isaac said? I can see a number of people saying they didn't hear anything.
Oh, okay. Thank you.
It's because everyone should be in the respective interpretation channel. That's why they couldn't hear the translation, what was said. So if everyone could go either to the English, the French, or the Portuguese channel, then we'll be able to hear everybody.
But anyways, let me just continue and say that the Isaac contributed that on top of Spectrum ensuring that they had...
Mateo, não sei se eu posso esclarecer sobre espaços seguros, se me permitir.
Yeah, I was just addressing the previous question quickly, if that's possible. So I just wanted to say that on top of Spectrum Uganda ensuring that there were clinics identified that could provide LGBT-friendly care, Spectrum Uganda has also a number of peer educators distributed across the country. So for this reason, every time a referral was made to a particular clinic, the peer educator in the area was also informed, and a connection was established when possible and when willing. When beneficiary was willing, then this other connection would be made to also support the referral. Thank you. Maybe Roberto, let's hear from you then the answer about the safe spaces and if they are the same or different from an office of the organization. Please.
Bom, muito obrigado. E obrigado pela pergunta que nos foi colocada em relação aos espaços seguros. Primeiro dizer que os espaços seguros nós tentamos na altura diferenciar entre os locais, os escritórios de funcionamento da própria organização com o espaço seguro. Porque o objetivo era estabelecer um local neutro onde a comunidade poderia de alguma forma sentir-se mais à vontade, livre de qualquer tipo de associação entre aquilo que se busca no espaço seguro com, digamos, o serviço burocrático que é feito nos escritórios. Então, resumindo, os 20 espaços seguros estavam fora dos escritórios onde funcionam as organizações. Por outro lado, também, eu queria acrescentar que nestes espaços seguros, para além dos serviços de socialização, como as festas, sessões de dança, karaoke, aulas, o acesso à internet, os cursos que eram oferecidos, nós também tínhamos lá serviços clínicos que eram oferecidos pelos educadores de par devidamente treinados para oferecer estes serviços clínicos, mas também semanalmente tínhamos brigadas que vinham de diferentes unidades sanitárias com as quais tínhamos acordos para oferecer serviços de saúde especializados. É um pouco que eu queria apenas esclarecer neste momento. Obrigado.
Thank you so much, Roberto. Let's move on with the next question. This question is from Kirsty. I hope I'm pronouncing your name correctly, Oglan. The question is the following. If I understood correctly, you mentioned the importance of securing a buy-in from the health clinics and government. Could you share a bit more about how you gained buy-in from Ministry of Health and the public clinics? So I think this is quite an important topic, as you know, it's a very critical step in project design and in project implementation to secure this type of buy-in. I would like to hear, if possible, from you, Patricia, because LVCT did a very, very particular work around this that turned out to be really successful in Kenya. So please, Patricia, if you have, if you could, if you unmute yourself and turn on your camera so we can see you. Thank you.
Thank you, Matteo, and thanks for that question. And I think based on our experience, we learned the key lesson, especially when you're introducing services for a population that has been experiencing a lot of stigma and discrimination and negative attitudes from providers. It is very important that you get the buy-in of the government, first of all, because in Kenya, the key populations are criminalized. So we had to create buy-in by bringing in the evidence and the importance for why we needed these services to be available for the LGBT community. So we held several meetings identifying who are the key decision makers, the key influencers, the people who can be listened to, especially by the health providers. And then also at facility level, we did a lot of work identifying who would be the service providers and who are in charge of those facilities, because we knew once we convinced the in charge, then it would be easy to cascade the rest of the services to the other providers. So there was a lot of investment doing an initial assessment to just get to know what is the attitude, the thoughts of the decision makers towards these populations. Are they willing to try out? And then we also offered the support to continuously take the key decision makers or through trainings and also dissemination of policies within the country to get that clear understanding. And in all our meetings, what we did was to bring in a member from the key population to begin to interact with key decision makers, just to put a human face to the acronym of LGBT. And that was really human. And eventually we took about the first 3 to 5 months of the project, just getting the buy-in. And once we got that, entered into an agreement with the county governments, the rest of the work was much easier. And they also formed a key part in supervision and really providing the technical support that was required to meet the quality of services. Thank you.
Thank you so much, for Patricia, for this explanation. I wanted to just maybe add just 2 things. The first one is that even that, you know, strictly connected to what you were just explaining about putting a human face to interface with government officials. One other thing that we did in the work with healthcare workers was of course to provide some initial training to health workers on the provision of non-discriminatory quality care for LGBT people, stressing also the quality aspect of it. In all of these training activities, we always made sure to invite LGBT people from the communities in attendance there to bring their stories, again, for the same reason that Patricia was telling you, to put a human face to people that we normally just hear, to groups of people that we normally hear just mentioned as key populations, you know, and people at times are, you know, don't understand or you know, have all sorts of reaction. And it's good to see how once this link is made, once people are able to put a face to a name, in a way, they also understanding and acceptance goes up, increases. Well, yeah, thank you. And I guess the other thing that I wanted to say, and really related to that, is that a winning strategy that LVCT Health adopted and their partners adopted in Kenya was also attaching a peer educator in all the facilities and ensuring also to have a person from the project seconded to all of the clinics. This particularly helps with all data collection issues that often arise, you know, when you ask already overloaded health workers to take on yet another task to do data collection for the project. So also this, you know, I wanted to say it's a winning strategy. But I wanted to move on to the few other questions that we have before in the last 2-3 minutes that we have before the next session starts. This is a question from Shivolo Awali, which is thanking for the presentation, but also in recognizing the significant and commendable work that has been done by the project IPs. He would like to know if we had the chance to also integrate data from non-IPs in the same regions where we were carrying out services. For example, Triumph Uganda has been referring LGBT clients to the public health clinics for testing and enrollment on ART in Bali during the same period. So, Pasquin, would you like to try and answer this question around if we managed to collect data from people referred from other projects? Thank you.
Yes, thank you for this question from Awali. As long as if the referrals came to the IPs, then we're able to record them and present them. But if the services were in other health centers that were not implementing this project, so this is really data that was implemented by the project. I hope that makes it clear.
Yes, thank you, Pasquin. I think that is clear. We have one last question now before we move to the next session. This is a question from, again, to Allied Medical Services about the healthcare strategy. TASA would like to know if there is any lessons from clinical service providers who were selected from public government health facilities compared to the NGO private facilities.
So Lazarus, just to explain that, what we learned is that the poor service provision and stigma and discrimination is a result of ignorance and lack of information. But when we trained the different health workers from both the public and also the private, as long as they have the information, as long as they have a paradigm shift, they will provide quality services. So I wouldn't say there was a difference as long as they got the training and they got the information and they have a paradigm shift, they will provide excellent services.
Thank you so much, Dr. Pasquin, for this last contribution. It's time now to move on to the second part of our webinar. We're going to be focusing now on LGBT people that have tested, and specifically on those who tested positive. And we're going to be looking at what happened with them in these three countries. So if up to now we've considered strategies that were employed by all these organizations in these three countries to provide prevention services, to raise awareness about HIV, and also to reach people where they are at the community level. Now we're going to be focusing on specifically those LGBT people that are living with HIV. So what I'm going to be so we're going to be hearing again from Patricia. Patricia will talk about the testing strategies we have employed in the project. Then we'll be hearing from Roberto. Roberto will tell us about the linkage strategies that were employed in this project. And lastly, we're going to be hearing from Dr. Pasquin. She will be telling us about the ART initiation and retention strategies. So the strategies to retain in HIV care the LGBT people who tested positive. Before going into that, I just wanted to quickly show you one slide only on the project's treatment cascade, which sort of sums up the results. Can I have the next slide, please, Kristen? Thank you. So here you can see the treatment cascade for the three projects. As you know, what is a treatment cascade? It's basically a tool that is used to assess if the project is managing to provide HIV care to all of the people living with HIV that have been identified. So you can see, starting from the left, the treatment cascade that was obtained in Kenya. You see that more or less, it's actually a very good cascade. We had out of 450 or more, I can tell now exactly, LGBT people who tested HIV positive, more than 350 have been linked to care, and practically the same number has been initiated in ART and has remained on HIV treatment until the project ended. So you can see, here I've summed it up saying that there is a relatively very small issue with linkage to care, but overall really a great cascade. Now looking at the central cascade, the one for Uganda, you can see here that the number of people identified as positive is higher in the end, so it's also becomes more complicated to follow up everybody. But we had like 1,000 and more people tested HIV positive. Almost all of them have been linked. Also, a very good proportion of them has been retained on ART. We see quite a drop instead in terms of the number of people being retained. So here a list from looking at this graph, it looks like there was an issue there with retention in care. We'll be going through the next slides to see if that was really the case or not. And sorry, now if you could go back. And the last, thank you. And the last graph, the one on the right, is the cascade for Mozambique. So here it looks like we have a sort of a different problem. You can see that out of more than 800 people who tested HIV positive, the project linked around 600 of them, between 500 and 600. And then though, which seems that there is an issue there with linking people to care. And then though the problem is the cascade looks quite well. So of all people linked, practically everyone has been retained in ART. Started ART and has been retained in ART. Just for the sake of this presentation, I just wanted to let you know that the definition that we have used of HIV retention in care was retention at the end of the project. Because of this being a 2-year project, adopting definitions of retention that are more standard and more in use was not really helpful to monitor the project every 6 months as we were required to do by the donors. All right, but without waiting any longer, I would like to introduce, pass on the mic to Patricia, who will start telling us about the strategies that the project adopted for testing. Thank you, Patricia.
Thanks again, Matteo. So I will take you through the HIV testing strategies that were implemented across the 3 countries. So on the right, as you can see, we engage various strategies to try as much as possible to tailor the testing and counseling services for LGBT people. So there was a safe space-based kind of testing by peer educators. Then we had assisted partner notification, social and sexual contact testing, home-based testing, mobile clinics or hotspot testing, and we also had facility-based testing. So in Mozambique, the peer educators were also trained as HIV testing counselors. So this made the home-based testing, the hotspot kind of testing, quite easier to do. In Uganda, index case testing and contact tracing was used by clinical partners to identify more HIV positive people. And in Kenya, the sexual contact was implemented to provide HIV testing to the partners of LGBT and especially bisexual men. Next. So in this slide includes numbers that one, the number of people who are actually tested and the number of tests. So as I take us through this, that would be like the basis of this presentation for this particular slide. So in Kenya, for example, we have 13,844 individuals tested, but in general, we had 44,113 tests conducted. Again, the basis of this was largely on the key population programming guidelines we have in country to have key populations tested every quarter. So we had a number of repeat tests throughout the 2 years of the project. That's why we have the 44,000. In Uganda, the actual individuals were 10,882, while the tests were 14,366, and for Mozambique, 16,847 actual tests and individuals and 15,780 tests. And that looks like a mismatch. But anyway, so the positivity rate in Kenya, we had 3.2%. And I know one of the things as we were implementing this, we really wanted to get to the national prevalence, which at that time was 18.2%. But what we also appreciated as we implemented the project is that now there was more access to services by the LGBT and MSM. And when we had the 18% at national level, there were fewer places where they could access services. So of course, there was the low uptake of services. But over the years, there has been a very positive response in terms of accessing services. So that explains why the low positivity rate. In Uganda, the positivity rate was 10%. And in Mozambique, it was 5.4%. So both in Mozambique and Kenya, we were below the national HIV prevalence amongst key populations. So in Mozambique, the HIV prevalence was low, as opposed to what was expected, that it should have been higher. But what they also realized was that in the northern provinces where there were more services, the prevalence was much lower, and this explains why we then have the two, Mozambique and Kenya, having lower positivity rates. Next. So in terms of lessons learned, in Mozambique, the external project evaluation found that HIV testing at the community level offered by LGBT peer educators was appropriate. Beneficiaries interviewed reported that it was important to have opportunities to test, especially the possibility to test from their homes. Yeah, but I think also just the connection and having the LGBT peer educators who already understand the complexity of the space made it much easier for them to be able to reach their peers with testing services. And again, for Mozambique, the LGBT peer educators were generally trusted by their peers. There was only one instance in which a peer educator disclosed to a third party the positive status of one beneficiary. So it's critical to ensure that the right peer educators are selected and trained, and a lot of emphasis on confidentiality. In Kenya, the social and sexual contact testing was considered to be a game changer. All people testing were encouraged to bring their sexual partners or a social contact for testing. The project team specifically focused on inviting the female sexual partners of bisexual men, and they were assured of confidentiality. There was a lot of emphasis, even as we trained the providers in the facilities, to maintain confidentiality, and even the peers. And we noted that throughout the 2 years, there was no single case where any one of them was outed, like to the other members of the community. So really the project achieved on the point of confidentiality. Next. In Uganda, the assisted partner notification services proved to be one of the most effective way in identifying LGBT people living with HIV who are unaware of their status. In Mozambique, peer educators were given monthly testing targets to achieve, with the performance evaluated every 6 months. Although on one side, assigning monthly targets made the project achieve and surpass its testing target, there was a risk that HIV testing was also offered to LGBT and MSM who were not eligible for the service simply to reach the monthly target. So there were situations where an LGBT had been tested maybe the previous month, and because of the pressure to bring in the numbers, they would be brought in again another month and another month. So that was one of the complexities in this implementation. In Kenya, the National Key Population Guideline requires that MSM tests for HIV on a quarterly basis. However, what we realized is that this was not practical. We had a number of them who kept on saying that they were not at risk. This affected the retesting rates amongst the LGBT people and the MSM. And the project began thinking around having more of a risk-based testing as opposed to just a routine quarterly testing. Again, in Kenya, beneficiaries tested positive for STIs had a higher probability also of testing HIV positive. So STI screening and treatment was actually integrated as part of the HIV testing services across the facilities. Next. So I take this opportunity once again to invite Roberto Paulo, the Executive Director of Lambda.
Bom, muitíssimo obrigado pela oportunidade, e vamos partilhar um pouco as estratégias de ligação, ou seja, o que é que, digamos, foi acontecendo com os beneficiários que eram testados positivos. O slide a seguir, por favor. Por favor, o slide a seguir. Hello?
Yes, this is the right slide, Roberto.
Next slide. Thank you. Obrigado. Muito obrigado. Bom, em termos de ligação para os serviços clínicos, concretamente o tratamento antirretroviral, nós tínhamos 3 diferentes níveis. Tínhamos o nível comunitário, tínhamos o nível dentro da unidade sanitária e tínhamos um outro nível que era nas clínicas móveis. Como é que acontecia ao nível comunitário? A partir da altura em que o beneficiário era testado positivo na comunidade, o educador de par que no caso estava ligado ao beneficiário testado positivo, tinha a responsabilidade de acompanhar este beneficiário para a unidade sanitária, e esta referência, bom, apesar de nós usarmos as guias de referência que eram oferecidas no projeto, mas também a recomendação era que esta referência deveria ser acompanhada para garantir que o beneficiário não volte antes de chegar à unidade sanitária. Então, ao nível comunitário, testado positivo o beneficiário, o educador de par acompanhava este beneficiário à unidade sanitária para iniciar o tratamento antirretroviral. Na unidade sanitária, também nós tínhamos beneficiários que poderiam, por exemplo, fazer o teste ao nível da unidade sanitária, e sendo positivo este resultado, o indivíduo lá na unidade sanitária beneficiava do aconselhamento e iniciava o tratamento antirretroviral na própria unidade sanitária. Agora, ao nível das clínicas móveis, há dois modelos. No Quênia e Uganda, bom, de acordo com a legislação vigente nos respectivos países, era possível que o indivíduo testado positivo ao nível da clínica móvel recebesse o pacote inicial de antirretrovirais no decurso da própria clínica móvel. Ao passo que em Moçambique a nossa legislação não permite o tratamento antirretroviral, ele só é administrado dentro das unidades sanitárias, o que significa que qualquer beneficiário testado positivo na clínica móvel, ele era referido para a unidade sanitária no sentido de iniciar o tratamento antirretroviral. Devo reconhecer que de uns tempos para cá, já ao nível do nosso Serviço Nacional de Saúde, há uma discussão no sentido de eventualmente se estudar a possibilidade de adotar estes mecanismos como este que foi sendo utilizado no Quênia e Uganda, mas é algo que ainda está em processo. O slide a seguir, por favor. O slide a seguir, por favor.
Yes, Roberto, there is a slight delay for the slides to get.
Bom, de um modo geral, olhando para aquilo que foi o desempenho do projeto, temos que reconhecer que nos 3 países, Uganda teve a melhor taxa de ligação, com cerca de 92%, ou seja, do total dos beneficiários testados positivos, conseguiram ligar 1.027 beneficiários. Em seguida foi Quênia, que teve o segundo melhor desempenho, conseguiu ligar 84% de todos os beneficiários testados positivos. Ao passo que Moçambique conseguiu apenas 65% em termos de taxa de ligação para com os beneficiários testados positivos. É importante sublinhar que algumas medidas foram tomadas, no caso de Moçambique, quando nos demos conta de que a taxa de ligação não era satisfatória, e uma das medidas que foi tomada foi assegurar a responsabilização, no sentido de que para cada beneficiário testado positivo, era a responsabilidade do educador de par que identificou este beneficiário ou o conselheiro que testou este beneficiário não descansar enquanto este beneficiário não fosse ligado aos serviços de tratamento antirretroviral. Slide a seguir, por favor. Bom, de um modo geral, nós aprendemos algumas lições e podemos nos referir que, por exemplo, no caso de Uganda e Moçambique, nós tivemos situações em que, infelizmente, os beneficiários forneciam contactos telefónicos falsos, e isto era muito comum acontecer durante as brigadas móveis realizadas nas zonas quentes. Bom, nós sabemos, muitas das vezes, isto não só acontece na população LGBT, mas na população em geral também. Há uma tendência de as pessoas, por conta do medo que têm para não ser discriminadas por ser HIV positivas, há uma tendência geral de não partilhar dados reais, e isso vivenciamos neste projeto, daí que foi um grande desafio assegurar estas taxas de ligação. Por outro lado, nós temos que reconhecer também que grande parte dos educadores de par da comunidade LGBT tem um nível de literacia infelizmente baixo, como consequência da própria discriminação para o acesso à educação, e isto fez com que em algumas situações as pessoas tivessem dificuldades, inclusive, de poder gerar o próprio código único, e isto foi um grande desafio no sentido de fazer o rastreio para garantir a ligação dos diferentes beneficiários. Há uma estratégia que é importante nós mencionarmos, que foi muito utilizada no Quênia, que foi providenciar crédito para os provedores de saúde. Este crédito, para além de servir como, digamos, uma motivação para engajar os provedores de saúde na ligação dos beneficiários testados positivos, permite de alguma forma que se possa evitar estas situações em que nos são fornecidos números de telefone falsos, e isto é aplicável também para os educadores de par. Aprendemos com este projeto que é sempre bom garantir que o nosso educador de par, quando ele vai à comunidade, o seu telemóvel tenha crédito, porque no momento em que o beneficiário está a fornecer-lhe um número de telefone, ele pode, tendo crédito, simular uma chamada para ver se eventualmente o número que ele recebeu do seu beneficiário é um número que funciona. Por outro lado, aprendemos também com este projeto a importância de nós garantirmos que tenhamos navegadores de par nas unidades sanitárias, que são pessoas LGBT, que são pessoas da nossa comunidade, que são de alguma forma instaladas nas unidades sanitárias. Elas facilitam o processo de ligação, porque quando o beneficiário que é referido para a unidade sanitária, ele chega à unidade sanitária, encontra alguém que é da sua comunidade, encontra alguém que é muito mais próximo a si, torna-se muito mais fácil interagir com esta pessoa que é da comunidade LGBT e ser esta pessoa a ajudar a navegar as diferentes portas dentro da unidade sanitária para que o beneficiário que é LGBT tenha um atendimento, digamos, mais favorável e de alguma forma desencoraje situações de desistências. Por outro lado, há uma outra estratégia que
Roberto, you have less than 1 minute,
e
please.
foi bastante bem sucedida, que foi a contratação. Obrigado. Que foi a estratégia de contratar educadores de par da comunidade positivos, que tinham a missão de assegurar esta ligação com outros beneficiários LGBT positivos e igualmente fazer buscas ativas encorajando as pessoas que eventualmente não queiram iniciar o tratamento antirretroviral pudessem o fazer. E muito obrigado.
Thank you, Pasquin. Can you go next? Thank you.
Yes, thank you, Roberto. Thank you. So I'm now going to take you through the strategy of ART initiation and retention in care. Next slide, please. So these are the strategies that we implemented in the 3 countries. In all the 3 countries, we offered same-day initiation of HIV treatment in both the public and also private health facilities. And in order to improve retention and adherence, there were some additional things we did. One of them was introducing nutrition support to LGBT and MSM who were positive and on ART, and this helped to promote adherence and retention in care. In Uganda also, we had adherence clubs that really supported the LGBT and MSM who were HIV positive on ARVs to adhere to their medication and also be retained in care. In Mozambique, a project nurse and a peer navigator and preferably one who is HIV positive, was assigned to follow a client who was positive but lost to follow or was not in care. So they would trace this person from the community and bring them to care. In Kenya also, health workers and facility-based peer educators organize psychosocial support groups to support the LGBT and MSM who were on ART to be retained in care and also to have adherence that will lead to viral suppression. In Kenya, health workers promoted to HIV positive LGBT and MSM services that they could benefit from the safe spaces. Next slide, please. Yes, I think this was already presented. That is the number of people, the results on ART initiation and retention. We see that in Kenya, we had 366, that was 98%. And of course, 97% was retained in care. They did very well. And in Uganda, we had 897 of them. That was 87%. People living with, started on HIV treatment, but 55% was retained in care. And as Matteo had explained earlier, it also depended on the definition of retention in care and the duration, but also it happened around the COVID time when data collection and also it was difficult to put them all together. Mozambique had 97% of the people who tested positive started on HIV treatment and 78% of them retained in care. Next slide, please. So what were the lessons we learned in ART initiation and retention in care? In Mozambique, for example, we learned that involving an HIV positive LGBT and MSM peer educator improved retention in care, and it really supported the facility staff to track beneficiaries that were lost to follow so that they can be retained in care. In Uganda, there were adherence clubs for LGBT and MSM, and these adherence clubs actually supported really with retention as well as viral load suppression. The adherence club had about 4 to 11 participants. We had a total of 71 members, and at the end of the project, they had 100% viral load suppression. And of course, also each health clubs received gender and sexuality diversity training. They performed medical checkups, refilled for the ART, and offered counseling, HIV counseling, and psychosocial support. In Uganda also, there was the adherence psychosocial support group that was provided with food, which was really so much needed. And this really motivated them and improved adherence because they had food to eat and they could take their medicine. In Kenya, there were also psychosocial support groups that helped the health worker. I mean, it was being led by the health workers as well as the peers. So this really created a wonderful environment for those who were tested positive. And of course, during those meetings also there were snacks. That was a motivation of the people who were in care. So they looked forward to eat and would come for treatment, and they were retained in care. Next slide, please. Yes, so at this point, I would like to put back the mic to the moderator from Frontline AIDS for further discussion. Thank you.
Thank you, Dr. Pasquin, and thank you everybody for the second parts of the presentation. We had Patricia telling us about HIV testing strategies, Roberto on the linking strategies, and Dr. Pasquin there on ART initiation and retention. We now have the opportunity to go through some questions and answers. There's been various ones put in the Q&A chat, which we'll go through. We're scheduled to 3 o'clock, but we'll try and finish in the next 15 minutes, but please do feel free to add any questions that you have for the panelists in the Q&A, and we'll go through those now. We have one first question from Yang. Could you share the mobile clinic work and service package and what kind of mobile clinics? We saw that the mobile clinic strategy was implemented in all 3 countries in slightly different ways. Perhaps I can open it up to Patricia if you are happy to talk a little bit about the experience in Kenya around the mobile clinics and how the mobile clinic work and service package were implemented.
All right, so from the Kenyan perspective, we had what we call the outreaches, where the peer educators would map out specific hotspots or places where we would find a group of LGBT people. And we would go with the package of HIV prevention, and that would include testing, screening for STIs, and also just being able to refer the LGBT to other services within the facilities, and for those who tested positive to also be able to start them on treatment. We also had something that we called in-reaches, and in-reaches was where the peer educator would actually mobilize their peers and bring them to the facility. So as opposed to the provider going out, now it was the peers who were coming to the facility to get HIV services. Thank you. Over.
Great, thank you so much. Roberto or Dr. Pasquin, would you like to talk a little bit about the mobile clinic strategy in the respective projects?
I could go first. Yes, so just like Patricia said, it's very similar, but in Uganda, what we did was we made it integrated so that when we go for a mobile clinic, we will provide prevention, care, psychosocial support there, and we will do a dialogue as well to discuss important topics and things that we were dealing with. But also at that point, we would do hepatitis B testing and also treatment, STI testing. So it's really very similar to what Patricia has said. And then also we have the peers, mobilizing the peers in the community, the LGBT and MSM in the community, and bringing them to the clinic or to where they can receive services. So it has been very similar.
Great, thank you, Dr. Pasquin. Any final thoughts from Roberto?
Bom, muito obrigado. Queria apenas acrescentar que, como foi dito pela minha colega, o primeiro passo para tanto as brigadas ou clínicas móveis é fazer um mapeamento, faz-se um mapeamento quais são os locais onde a comunidade frequenta, faz-se um mapeamento, por exemplo, quais são os melhores horários em que as pessoas estão concentradas nesses locais, quais são os dias de pico, e logo a seguir, então, organiza-se esta brigada, que geralmente, quando se tiver condições, é um trailer que tem todo o equipamento médico, se instala o trailer no local previamente indicado, e os educadores de par, eles fazem a criação de demanda, recrutando as pessoas que estão naquela zona quente e encaminhando estas pessoas para aceder aos serviços clínicos. Geralmente é assim como funciona. E em Moçambique, como dizíamos, nós não fazemos a provisão do tratamento antirretroviral fora das unidades sanitárias, então qualquer indivíduo testado positivo, são tomados os contactos desse indivíduo e ele depois é referido para uma unidade sanitária onde vai receber o tratamento antirretroviral. E geralmente estas clínicas e brigadas nós fazíamos aos finais de semana, sendo preferencialmente entre sextas, sábados e domingos. Obrigado.
Great, thank you, Roberto. Okay, moving to the next question. It's from an anonymous attendee, and it's specifically for Kenya, so Patricia. So what was the HIV prevalence rate in the Busia population in Kenya higher than the other project locations in Kenya? And that's given the proximity to the Ugandan border, or was the prevalence rate across locations in Kenya lower?
Thank you for that question. So the prevalence across the project, we had higher prevalence in the western region. So western would have Bungoma, Vihiga, and Kakamega counties, and it's because the coverage for services there was slightly lower than Nairobi and Mombasa counties. So Nairobi and Mombasa had lower prevalence. Thank you.
Great, thanks, Patricia. The next question is from Bernard Wasiki from Hope Mabale. Thank you all for sharing this important information. I would like to ask if the project's reports will be shared to all IPs in different countries. So this is raising an important point around data and project results and how we communicate those to different implementing partners and communities. Would anybody from the panel like to tell us a little bit about their approach around that and how the project reports are shared with the different implementing partners?
So if I may go first, probably how we did it. So all our project reports, we wrote them together with the partners who we were working with, especially representing the LGBT MSM community. But beyond that, there were so many abstracts that were done with the facilities and also the community organizations and the peer educators. We also did a technical review that's available on the LVCT website, and we also disseminated it across different platforms to ensure that this information is out there. So as much as possible, I would recommend that if you can do a document that can be available to everybody, like now the technical reviews or a policy brief that will be put out there and people can learn from the project. Thank you.
And Dr. Pasquin or Roberto, did you have anything to add in terms of the communication back to the different implementing partners level? In Mozambique, we had Amadefa and Lambda as the two primary partners, but Dr. Pasquin, go ahead.
Yes, thank you, Savita. So also in Uganda, we have the practice of sharing the results of the services we've been providing with all partners, and that will be done. I think the last meeting we needed to have was when COVID, the pandemic came in. So, but otherwise we normally share with all partners.
Great, thank you. In the sorry.
Bom, no caso de Moçambique, tenho que reconhecer que implementar este projeto nos moldes de um consórcio foi um desafio. Foi um desafio porque, no nosso caso específico, nestes moldes estávamos a começar, então precisamos ir aprendendo com o processo. Devo reconhecer que, por exemplo, tínhamos estabelecido algumas plataformas de comunicação com o ONU-SIDA, com o Conselho Nacional de Combate ao SIDA, com o Ministério de Saúde, mas infelizmente não conseguimos implementar na mesma dimensão que tínhamos planificado, mas conseguimos, à medida do possível, pelo menos informação programática entre nós, a Modefa e outras pequenas organizações que tinham sido contratadas pela Modefa para apoiar no trabalho, conseguíssemos ter encontros regulares. Obrigado.
Great, thank you, Roberto. Dr. Pasquin touched on COVID or mentioned it there, which is a good segue into the next question. So this is from Sally Shackleton. From the presentations, it seems psychosocial support, social support and solidarity, snacks and hygiene service were key to retain people in care. So how have these services been adapted under COVID-19? and thanking the participants for a great session. But yeah, the question focuses on COVID-19 and how have some of the key areas, the key strategies that seem to have been effective, been adapted to continue to support populations during COVID-19. Dr. Pasquin, I've seen you put your video up, so please go ahead.
Okay, so this is a good question because COVID-19 is still with us, and COVID-19 actually changed the world and the way things were done. So we realized quickly that if we did not put any innovation in place while we're trying to do infection prevention and control, then all the gains we have made, especially for key populations, that they were still lagging behind in HIV treatment. So we put strategies in place to provide all these services despite COVID-19. Actually, these were more needed now than before. So we've still been providing psychosocial support. We've been using mobile support, virtual support, and also physical support where it was possible, using, of course, the standard operating procedures. So we've put all this in place to support the key population. We've been providing psychosocial support still, including food and even infection prevention supplies like masks, sanitizers, and we have also, in some cases, we've done some cash transfers to people who really would be badly off without any support so that they could get food to eat and also some basic needs. Thank you.
Great, thank you, Dr. Pasquin. Go ahead, Roberto.
Bom, não sei, queria acrescentar alguma coisa. Bom, muito obrigado, Savita. Bom, com a situação do Covid, eu devo dizer que para nós, Lambda, este projeto, devo confessar isto, este projeto trouxe-nos ferramentas que neste momento estão a tornar a Lambda em melhor posição do que outras organizações, porque aprendemos com este projeto a estratégia virtual e isso nos permitiu, quando começou o Covid, rapidamente nós ajustamos os pacotes de serviço que nós temos e passamos a utilizar as estratégias virtuais, como, por exemplo, adquirimos telemóveis para todos os nossos educadores de par em todos os programas. Estamos a usar muitas plataformas como WhatsApp, Facebook e outras páginas que a partir dali nós contactamos os nossos beneficiários e oferecemos os serviços que estamos a oferecer. Igualmente, para no caso específico do Covid, estamos a oferecer os desinfetantes, estamos a oferecer máscaras, tivemos algum apoio, inclusive, dos fundos rápidos da própria Frontline, que nos permitiram aumentar a oferta destes produtos de proteção. Estamos a oferecer cesta básica para alguns beneficiários, por exemplo, sobretudo mulheres transgênero, que estão envolvidas no trabalho de sexo, que ficou comprometido por conta das restrições impostas pelo estado de emergência. Então, vamos tentando, de alguma forma, mitigar a situação, mas queria, de um modo geral, dizer que, graças à implementação deste projeto, nos permitiu saber que era possível oferecer serviços numa base virtual. E estamos a conseguir. Obrigado.
Great, thank you. We only have time for a couple more questions, unfortunately, in the interest of time. Kenneth asks, are clinical outreach the same as mobile clinics? Perhaps I can talk to that in the interest of time. So the mobile clinics tend to be set structures, either tents or caravans that are situated within different project sites that are strategically considered in sort of frequented areas where there may be access to the LGBT community. And the clinical outreach through the peer educator structure, at least, is very much around peer educators reaching and linking different clients to different health facilities, and then the health facilities also providing that outreach service.
Sorry, Savita, just on this one, because just to clarify that in Uganda specifically, what organizations that are called clinical outreaches is what we would call mobile clinics in the other projects. So in this particular case, yes, it is the same concept, right? The way it was done in this project in Uganda equals the way moonlights were done in Kenya and the mobile clinic strategy in Mozambique.
Great, thanks for that clarification, Matteo. We have time for one more question. And apologies that we're not able to get through the rest of them. We are very happy to share the presentation after for all the statistics and information in it. I'll take the final question from Arthur Mubiru. So can AMS start providing STI drugs to our clinics, DRCs, since they are easy to access?
Thank you, Arthur, for that question. I don't know what you mean by easy to access, but the STI drugs are purchased, so I can't say we'll be able to distribute them to the drop-in centers. We have the STI drugs at the clinic, so it will be easier because they're very limited. It's not like limitless. So if there will be opportunity where they're available, yes, it can be done. But for at the moment, we don't have that much that we can distribute to the drop-in centers. Thank you.
Thank you, Dr. Pesquin. That brings us to the end of the webinar. And from my side, I'd like to thank all the panelists and the Q&As for this section and to all the participants. And I'll hand over to Matteo to close the session.
Thank you, Savita. And thank you everyone for staying with us until now. No, I really didn't prepare any closing remarks. All I want to say is that we organized this webinar specifically because we know that designing projects for LGBT people, it's not always easy, especially in context where LGBT people are criminalized. So we're hoping that by providing the lessons learned from 3 separate projects in 3 separate countries that, yes, have different social backgrounds, but still, there are some similarities that we thought could make it interesting for you to hear how same problems were tackled in different ways in the 3 countries, or in similar ways in some cases. So just that, I just maybe if I have one thing that I want to say is to, of course, as you probably noticed, all these strategies, all these interventions heavily rely on the role of peer educators. And what I'm noticing, at least in my experience as implementing this type of project, is that you come across very often projects that do not acknowledge and recognize the role that peer educators have in these projects, that are completely founded on what they can do and on their commitment to the project. So I really, really hope that in the future we can see projects that, like these ones that we have described today, that really pay tribute to their role and that recognize that in economical terms, but also, of course, with mentoring and skills, and build their capacity. And that's it, really. I just wanted to thank one more time our speakers from LVCT Health, Patricia, from Lambda, Roberto, and from Lab Medical Services in Uganda, Dr. Pasquin. Thank you so much, and the recording will be available. Thank you. Bye-bye.
Thank you, everybody.